So greetings from New York. My brief today is to talk about an Irish public genome project. So that's going to be the focus of my talk. I'm going to break the talk into 4 sections, talking about clinical genetic services and where genomics fits into that, because I think the healthcare perspective is what I can offer, and it's ultimately what the deliverable of a public genome project should be. I'm going to give a vignette or two about understanding the population you serve, and that this is understanding from a genomics point of view, and then move into the discussion of public genome projects and how this could be done in Ireland in particular. So in genetics, we have 4 areas of subspecialization within my specialty, which are probably familiar to most people, and they're shown here. The 5th area of common diseases is emerging. It's something which has really lived in the research realm, but now that we're getting better at identifying the genetic factors that are involved with predisposition to common diseases, it's increasingly becoming part of the discussion, although it intersects a lot with public health initiatives as well. So I think from right to left, you're seeing a gradient of having more potential for intervention and therapy, whereas over in the prenatal and rare disease side of things, we're more focused on diagnostics and family reproductive decisions. So where does genomics fit into each of these areas? In the prenatal area, obviously before a couple has a child, there's the carrier screening option. Pre-implantation genetic diagnostics, as shown here, remove one of the cells from a 6-cell embryo is shown, and you can test to see whether the family has an embryo that's affected, and you can implant the ones that are not. And then fetal testing has moved from the invasive techniques of amniocentesis and chorionic villus sampling to the non-invasive prenatal screening approach. Although to confirm diagnosis, we often then have to move to one of the more invasive approaches. So there's genetics involved in each of these different applications. In terms of problems, just to emphasize, in New York, if we're doing carrier screening and we have Ashkenazi Jews as the couple who are coming in to study, we need to look for Tay-Sachs disease. You don't really need to look for Tay-Sachs disease on a population level in Ireland, because it's a different kind of a population. And likewise, the Delta 508 mutation that is associated with most of the cases of severe cystic fibrosis in Ireland, it has to be recognized that this is a mutation that exists predominantly in Northern Europeans and not in the indigenous people of other parts of the world. So you need to tailor your carrier testing accordingly. Rare diseases are often dismissed as being rare, but cumulatively rare diseases account for about 8% of the population. So we really have to have good ways of diagnosing these conditions. And these are underpowered genetic association studies where we're testing a proband and one or both parents. And it's an inherently limited approach in terms of trying to associate genetic variants with the information describing the patient, the phenotype or human phenotype ontology terms when it's standardized. And this is an inherently difficult process, with the result that with exome sequencing, where you're sequencing every one of the protein coding sequences in the genome, or even whole genome sequencing, which offers some advantages, we're still only able to make positive diagnoses in rare disease in 12 to 38% of cases. And this is our NYC KidSeq study, where we're ranging about 16 to 17% positive rates. So the majority of time, even though we're sequencing the entire genome, we're not able to come up with a diagnosis. And it should be noted in that category that there's more testing happening, including by our other colleagues in other specialties. And this is a good thing, but it's also difficult to provide the services required to support all of this testing. Cancer genetics is one of the home run areas of genomics in clinical medicine right now. We can do the testing before somebody develops a cancer to see if they have a cancer predisposition in their family. Early detection is being developed with things like cell-free DNA in the peripheral blood. And then if you develop the tumor, sequencing the tumor itself or genome-wide, or looking for the specific mutations that would prompt a specific therapeutic intervention, so-called companion diagnostic testing, are wonderful innovations that are being pushed right now to try and help outcomes for people who have these tumors. And there are many different eclectic areas of biomarker development which are very interesting, including the ability to infer what the inflammatory cell subtypes that are present within a tumor, which is important in some of these new immuno-oncology approaches. Problems with cancer, we have to do a lot of sequencing. That's not really a huge issue, but we have fewer actionable outcomes than we would like. It would be great if every time we sequence, we're coming up with something which would help that patient, but it's only in a subset that we're able to do so right now. Biochemical genetics is the area of metabolic syndromes, like people would know about phenylketonuria, which is a relatively high frequency in Ireland. Biochemical testing, because of the uncertainty that we have about the DNA sequence variants, a lot of the time you would never make a diagnosis of biochemical disorder without actually confirming that the biochemical derangement is present. But once you've found the mutation in the family, then you can go and test other family members with so-called cascade testing. So it would be great if we could move newborn screening to a purely genomics-based approach, but right now we still have to integrate both biochemical testing with genomics, but this is another very exciting area. Common diseases, as I say, we're beginning to understand more about common diseases. What I'm showing here with the blue component to the pie chart is the proportion of people in these different parts of the world who have a specific missense mutation in the PNPLA3 gene. And as you can see, if you have East Asian ancestry and related to that Hispanic American ancestry, you're much more likely to have this missense variant, whereas if you have sub-Saharan African ancestry, you're much less likely. And this is a driver of risk of developing non-alcoholic fatty liver disease in the first place, and for having a worse outcome in terms of cirrhosis and the need to progress to liver transplantation. So genes of major effect we're beginning to recognize for common diseases like fatty liver disease. And we're also recognizing that a lot of these conditions are driven by multiple loci throughout the genome. So this has allowed us to create what are called polygenic risk scores. So this polygenic inheritance of different conditions, if you look at the polygenic inheritance of a trait like height, and then you've developed it in say a Northern European population, you try and apply it to a Black population, you will find very little crossover between the loci that are predicting height in one population and another. So you have to develop these calculations for the population that you serve. And obviously what you're calling a common disease could be quite different in Ireland compared with what it might be in the Bronx in New York. If you're doing a lot of sequencing, there are other things that you could optionally report back to the family. So the American College of Medical Genetics has defined 59 medically actionable genes. And if you can read the small print here, you should be able to see that some of them are BRCA1, BRCA2. So cancer predisposition genes are shown in the reddish colors. Cardiac predisposition genes like FBN1, which causes Marfan syndrome, shown in green. And this is a result of the return of results that from the Geisinger healthcare system, where they're offering this to their patients. About 2 to 3% of the time, you'll find a medically actionable gene. You can also offer people's carrier screening and pharmacogenomic profiling to see if they are likely to have idiosyncratic responses to certain drugs. And you have to make sure that you set this up in such a way that people really think through the implications of getting these incidental and secondary findings. You know, are you really prepared to know that you have a risk of developing breast and ovarian cancer if you're a woman, or prostate cancer if you're a male? And also there's, 23andMe sells this BRCA test, but it's only 4 mutations. You get yourself tested, you find no that you have a negative result. This is actually leading to a funny, strange risk called false assurance. You get a negative result and you think that you're probably fine, but they've only looked for 4 mutations and you could actually have another mutation in there. So the next point is you're offering these services, but you're going to be offering these services in a different way for different populations. So the Bronx is where I work. It's the most diverse county in the United States based on the 2010 census figures. It's also has in the South Bronx the poorest congressional district in the United States. So we see economic challenges and an extraordinarily diverse population, and it makes my job very, very interesting. And I mean that in a positive way. So I want to give you a vignette. A kid that I saw in clinic who was referred with a foot deformity, hip dysplasia, and this sort of hollowed out chest appearance of pectus excavatum. No family history of anything similar. Mothers from Central and Caribbean American ancestry, father Puerto Rican, and there's no evidence of consanguinity between the families. I also noted that he had some craniofacial features as described here. So typical first line approach before you sort of think too deeply about such patients is to look and see whether they have any copy number variants, or areas of DNA that are present or missing that shouldn't be. And while he didn't have any deletions or insertions of DNA, he had this one area at the distal end of chromosome 9q where the DNA was homozygous. In other words, it was exactly the same DNA sequence that he inherited from his mother and from his father. And this is something that you see when families are distantly related to each other. They didn't believe themselves to be consanguineous, but clearly they were to some extent. So this region contains a gene called COL27A1. It's a collagen gene. And in Puerto Ricans, it's something that we know in the Bronx to be containing a relatively high frequency missense mutation, which is inherited from the Taino Indian indigenous precursors of the modern day Puerto Rican population. And when I sent that test with this 9q isodisomy observation, it came back positive for this mutation, homozygous. He has what's called this Mendelian condition called Steele syndrome. So this is important because if you have a kid with hip dysplasia and he's not responding to the conservative measures and you're thinking of doing surgery, don't do the surgery if you've got Steele syndrome, because you can end up in a wheelchair. The results of the surgical interventions have been described as dismal. So it's important to know which kids could be at risk of that. So the lessons from this kid, as this one vignette, is that there may be mutations. You're not going to be testing for this particular mutation in Dublin or Galway or anywhere in Ireland, because it's going to be vanishingly rare in the Irish population, but it's common in the Bronx, and vice versa is also going to apply. And if we know the mutations and diseases in the patients that we serve in our healthcare system, we can actually provide precision medicine on a community level. And this is something which would be a good outcome of some sort of genomics approach to your population. Now, I don't know Martin McGuinness's genotype, but I know that he died, it was in the public domain that he died of familial amyloid polyneuropathy, which is something which causes this buildup of amyloid in different tissues in the body and often will cause you to die from congestive cardiac failure. And this is a relatively late picture and he looks very unwell. The reason that I'm bringing Martin McGuinness up is that he's from the northwest of the country, and there's a study from 1995 which found that in this mapped region here, 1.1% of people carried a mutation in the transthyretin gene, TTR, and not all of them had a disease, not all of them had amyloidosis, because it's incompletely penetrant. But if you have somebody who presents with cardiac failure and their family is from this part of the country, or they have a surname which is recognizably from this part of the country, while typically you'd think of more common causes for the cardiac failure, you should start thinking in terms of transthyretin related problems, especially because of the fact that there are now potential therapies that you can use that could help these people in particular. So this is the equivalent of Steele syndrome in the Bronx. You've got a transthyretin mutation, which is potentially overrepresented in Irish patients. So let's talk now about public genome projects. We've kind of gone from the general and let's get into the particular. So there are numerous government-funded national genomic medicine initiatives, excuse me, that are being performed around the world. Excuse me, this is a map from 2018. It's already out of date, but as you can see, there are many initiatives that are ongoing and are actually maturing at a great rate at the moment. And the one of these that I think would be a great model for Ireland is the Finnish model. It's a very similar population size, and it's also we don't tend to represent the Finnish genotype as being similar to the rest of Europe because it was an isolated population for a very long time. And this can lead to things like this Steele syndrome mutation in the island population in Puerto Rico. You can have what are called founder effects on the genetics of the population, including founder effect mutations. So Ireland is likely to have founder effects, and at least I hope so, and I'm not unusual, because this is my genome. This shows in general where I'm heterozygous, but there's this large chunk of about 7 million base pairs in the middle of chromosome 4, where the DNA is identical between my father and my mother. Now, my father's family is from East County Galway and County Clare. My mother is from Roscommon. So it's quite possible that there was a very distant ancestor that was in common to both families. And you end up with this memory of it within the population. So this is hopefully not something that I'm alone in having, but I've heard from my colleagues who are studying Irish genomes that this is something which is seen in quite a few individuals. So what I've just done there is I have revealed to you, I've looked at my own genome and I've revealed to you something about my parents. And this is one of the reasons why we need to think in terms of the risks that are associated with genetic information, because when you test yourself, you're testing the rest of your family. Your first degree relatives will share 50% of DNA with you. Your second degree relatives will share 25%, third degree 12.5%, and so on. So if you're making a decision that you're going to test yourself for BRCA1 or BRCA2, you're in effect testing others in your family as well. And then the question becomes, what are you going to do with positive or negative information in that situation? What's your responsibility to the others in your family? And what's your responsibility either to say something or not to say something? A second, there are many different risks that we can talk about. You can individually suffer harm from genomic testing. It's pretty well documented in the United States that while we have a law that prevents discrimination if you, in terms of provision of health insurance, if you are found to have a genetic condition, that's the only insurance it covers. Life insurance, disability insurance, you can be discriminated against still because of genetic findings. And this is something which we have to bring up with patients before we do any testing. You can also have this false assurance if the tests come back negative. You can have group discrimination. I'm very concerned about, in Ireland, the possibility that the Irish traveller or Minkeri community could end up being seen as genetically different and genetically damaged in some way, whereas the truth is that everyone has the same number of mutations. It's just that you have to be able to understand that how to deal with different groups. And I've already victimized people from Donegal in my presentation here. You're now going to think of people from Donegal in a different way. And this is an example of the kind of group discrimination that can occur when in terms of mindset, and that can then end up reflected in other ways. For children, you're not going to tell them they're at risk of cancer as they grow up. This is the principle of the right not to know. And there are scoundrels out there who will take your DNA sequence and overinterpret it for their own profit motives. And so that's something to be avoided. But I also want to bring up another vignette. And this is to point out that just because we can do genomics doesn't mean that we should do genomics. And this is a situation that was prompted by our recent experience of COVID-19 in New York City and in the Bronx in particular. 1 in every 350 people in the Bronx has now died of COVID-19. We were hit extraordinarily hard by this pandemic. And as you can see, we have the highest death rate per capita of all of the 5 boroughs, with Queens second. So when I was presenting these data to colleagues in New York City, big COVID-19 genomics consortium, I had multiple offers from academic and commercial partners to sequence our patients, because the idea was you've got a diverse patient population, you've got a distinctively higher death rate, so therefore we must be able to find something genetic. So we discussed this internally in our healthcare system, and we declined the offer. And we declined the offer because of 2 things. One is that we recognized that the facts on the ground were that the reason people were dying at this high rate was because of health disparities and racism. The problem with some of the patients, for example, and this is published in JAMA, was that they weren't turning up for care because they were afraid they're going to get picked up by the immigration agents, because some of them were undocumented. So they were presenting later in extremis and therefore had a worse course. And we're also unwilling to feed into a racist narrative that says that the Black and brown people that we serve in the Bronx are in some way genetically defective. So we declined the sequencing because we didn't want to create a distraction, and we didn't want to feed racist trolls. So let's talk about when they do these genome projects, how do you deal with these sort of sensitive issues of genetic information, genomic information? And Finland, I'm going to hold up as the example. There are plenty of examples, but I think Finland is a really good one. They set up a working group in Finland of experts, and they organized workshops, brought in stakeholders from multiple fields, kind of representing what we're seeing today in this meeting. But they also made sure that they had public input through these existing services that they had online. And by the time that they put everything together, they had consensus. They had a unanimous proposal involving the experts, involving the public, and they submitted it to the appropriate ministry. The legislation that governs the protections for genomic data in Finland, to some extent, predated this initiative. The Personal Data Act and basically influenced GDPR, which came later. The Biobank Act was a foundation for moving forward, but since then they've passed the Secondary Use Act, and this separate Genome Act was due to be passed this year, but I think it's been delayed. So the nice thing about performing all of these protections is that there's clarity for people involved. Whether you're in academia, whether you're in industry, you know exactly how to do your studies, and in a way that is going to be in compliance with the regulations that are in place in the country. And importantly, the public, the participants in your study, know exactly what they're getting into. And one of the reasons that there's confidence by the general public in Finland that they have this agency, they have control, is because they have been given full control over their personal data. This my data system that they put in place, it's explicitly required that they are given the ability to own their own personal data and share it as they see fit. So what's the scope of what they're trying to do in Finland? They want to sequence 500,000 Finns, which is about 10% of the population, which will allow you to infer not only the common variants in the population that exist in 1% or more people, but also the rare variants that are present in most Finns. And it's a paradigm of public investment driving commercial entities. So they have this entity, Business Finland, which is not only trying to build small and medium-sized enterprises. It has initially recruited 7 pharma partners. That's up to 9 now, and it's a true private-public partnership, but it is driven out of the government as the brokers with the population of the country. And the way that the money is being broken down, half of it is being spent on the biobanking. Only 14%, one seventh of the total, 80 million euro, is being spent on the sequencing. The sequencing is not the expensive part of a genome project. The biobanking, by a long shot, is the highest amount, followed by the data analysis and processing. And of the 80 million, 20 million is coming from the Finnish taxpayers, and they've leveraged 60 million from their pharma partners. And this is not over 1 year, this is over multiple years. So it's the actual spend per year is quite low. So what are they aiming to get as a return on their investment? In 2015, when they put together the proposal, they were talking about with diabetes, with cardiac disease, with hereditary cancer syndromes, that they wanted to knock off a few percent by predicting who is at risk. And if they could do 2 to 5% reduction in diabetes and associated comorbidities, they could save 28 to 70 million euro per year. And it should be a similar scale of savings that you'd be talking about in the Irish healthcare system, which has similar rates of diabetes and cardiovascular disease. And 5 years later, they just published in Nature Medicine their first polygenic risk scores for cardiometabolic diseases and clinical risk scores for common cancers. So they're now at the point that they are going to be able to identify the people who are at risk and be able to have effective interventions. So now let's focus in on Ireland, and to finish this, how should you do a public genome project in Ireland? Well, first thing is don't reinvent the wheel. Learn from our peers. Finland is one place where this is happening extremely effectively. The Genomics England Limited is another example. There are plenty of examples around Europe and around the world that could be used as paradigms for how we could do things in Ireland. And the Finnish example is very clearly starting with public engagement and legislative actions that make sure that you have protections in place and clarity about how to perform your research. You probably don't. It's nice to sample 10% of the population, but if you really want to get something started, you could start with maybe 10,000 people, which will, if you're sampling, if you're just sampling, you know, in the center of Dublin or something like that, that's not going to represent the population. You need to sample the entire country, and it should be an island-wide initiative, and this would give you a lot of valuable data. So a cost estimate, so that people have, this is got a little bit of concrete to it. I talked to a commercial / academic provider about what it would take for 10,000 participants in the study. I don't call them patients, I don't call them subjects, but participants, because they're involved. And if they request medically actionable gene information, carrier screening, or pharmacogenomic profiling, the genetic counseling resources would be in place to return that to all 10,000 if needed. And the projected cost would be between 10 and 12 million euro. And this would also generate high depth whole genome sequencing, as well as the genetic counseling. So this gives a sort of a ballpark figure that could start a public project in Ireland. One question that comes up, and I'm going to finish with this, is how would you keep such data protected? And how can it be private and yet public? And this is the way that this happens is through authorized access public databases. In America, it's dbGaP. In Europe, it's EGA. And it basically requires that you are verified as a serious user, an academic user, for example, that you agree to abide by restrictions on the use of the data. And obviously, if you break any of those rules, you could lose your job, you could lose your funding, you could certainly lose your access to further data. And the Global Alliance for Genomics and Health is a great worldwide body that is helping to drive these standards to help guide what could happen in Ireland. The unusual opportunities for Ireland, it's really encouraging to see SFI investing in training 115 PhD scientists in genomics data science. These scientists are going to be qualified and looking for things to do. So a genome project in Ireland that allowed them to get their teeth into what's affecting our own population would be a phenomenal resource. If you find something in Ireland, there are tens of millions of us overseas who are genetically related, and that opens up not only commercial possibilities, but also why not apply for funding from places like the United States, Britain, or Australia. I'm very excited by the idea that the medical device companies who are developing wearable technology could get involved in terms of some of the public health interventions, like early intervention in type 2 diabetes if you have a polygenic risk score that identifies people at greater risk. And the GP community in Ireland is potentially a way to have innovative delivery of healthcare services when you have to do it on a public health scale, which is not something that clinical geneticists like myself are really able to deliver because of the nature of the way that we intervene with patients, which is lengthy and small volume interactions. So I'm going to leave these as next steps for you. It's things that I've already outlined, and then we'll move over to any questions that you may have, which I'll be happy to answer.
Thank you so much, John. I think you answered a lot of questions as your presentation rolled on. And I think the case studies, both from Donegal and the Bronx, and I think I speak for everyone here in Ireland, we have a huge amount of sympathy for your colleagues in the Bronx and what you've all, I'm sure, had to deal with COVID, and the very ethical decisions you made around your genomics and that patient population is to be applauded. So well done. I'm not going to ask a question, even though I have about 10 in my head. We're a democracy here, and we have a poll, and the very top of the poll is from Jacqueline Turner. Where do we start to introduce a system like Finland in Ireland, and what are the steps we need to take? Now, I know there's another question further down that applauds the financial breakdown and how interesting it is, you know, from the biobanking perspective. So, I mean, you've a great, because you're Irish, you might have a view on that.
I think when Avril was doing her introduction, she talked about how there's this sense that we need to have a national genomic strategy in Ireland. I know that there is hiring, which is directed towards that goal. I think that I think that's the first step. But rather than this becoming the purview of some overworked civil servant somewhere, I think this is something where the citizens can drive the debate in equal part with the elected representatives and the civil servants who are, you know, I've found to be very well informed and very well intentioned. But this needs to involve a wide range of people bringing their collective interests and expertise to the table. And I would ask the Finns, you know, how did they set this up, and how can you get true participation?
I will say that I do know that some officials in the Department of Health have reached out to Finland in recent times. So I hope that's a good sign that someone in there is thinking like yourself. But I can't speak for them. I don't believe they're here. But just to be fair to them, I have heard that. The second question is from Robert O'Connor from the Irish Cancer Society. And this is, he would welcome any thoughts from you about how we should protect the public from over-interpretation for profit. And that's something you did talk about. Seems like not just false selling, but in many cases is being used to profit from the genetic information paid for those paying for their analysis.
This is a worldwide problem. It's not something that Ireland needs to solve on its own. Clearly, God, I live in America. We have, you know, misinformation which has been pervasive here for you know, especially recently. You can never really stamp it out, but what we can do is we can educate. So if there's a debunking of garbage as it comes out, and if there's some trusted resources that people can turn to ask questions, and these need investment. You know, people will turn things around, you know, if you send them a message on Twitter or something like that, but it's not the same as having, you know, policy documents, white papers, things that really help to give consumers a sense of where they should have trust and where they should really be careful. Education.
And hopefully our discussion paper at the end of all of this will help maybe push towards a white paper, because I think you're right on that. Just finally, and I think this is really important from the participants, the patients, the public's perspective, you know, food for thought around genetic counselling, because that's hugely under-resourced. I know that in cancer, I know that in rare diseases, and that's a question from Francis in Breakthrough Cancer.
Yeah, so this is actually part of a bigger picture of how do you provide genetics resources, because our paradigm in the past has been, and it's been very nice, to sit with a family for an hour, have the box of tissues out when you're giving the bad information. It's a lovely, empathetic interaction. It's necessary if you're going to educate families fully about what they're going through, and it's completely unscalable. So we cannot, in the United States, certainly, we can't train genetic counselors quickly enough. So we're beginning to look at new ways of delivering information that kind of break the comfortable paradigm. So things like web-based electronic media, lots of visual aids. And the question is, how do you get a genetic counselor who used to see one family per hour to be able to get 6 families per hour seen? So you need numbers, definitely. We need to train them. We need to certify them. We need them to have structures that they can work in. But you also need to have the ability to have them work in ways that deliver care much more broadly. And it could be that what we want to do is to have sort of initial, here's a printout of what's going on with you, and then a second phase will be, after you've got that, here's the ability to ask some questions remotely, and then in a third phase you may have a smaller number of people actually coming for some sort of interactive session, whether it's like this or in person.
And I know there's patient organizations out there frantically nodding their head to those comments, and I can see in the chat box, John, you might want to reflect on some of the comments made to you. Probably some people you know, like Liam Gallagher, and I know that Anne Lawler from 22Q11, hugely interested in this space and very supportive of your talk today. So thank you very much. Great to have an Irish man in New York speaking to us about this topic, giving us really solid advice that I know we all appreciate. So very, very well done, and thank you. And we're going to move now to the panel discussion.